Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
I'm Dr. Erica Bostick, and I'm an adolescent medicine physician and faculty on CEI. And I'm thrilled to be here with my colleague, Dr. Stacy Sun. Stacy, can you go ahead and tell us a little bit about yourself?
Yeah, hi, I'm Dr. Stacy Sun. I am an OBGYN family planning subspecialist at the University of Rochester. I've been here for around 6 years. I have the specialty in complex family planning, which is specifically taking care of people with abortion and contraception.
Thanks for being with me today. And I don't know about you, but our theme for today is very pertinent to the day-to-day experience that I have, which is misconceptions in contraception. There's so much out there, and I think there is a lot of misconceptions out there as well. What is your take on it?
Yeah, absolutely. I think that since the advent of social media, we used to always have the internet, and there was a lot of misinformation out there already. But now with social media, with influencers, and with quote unquote doctors who don't have a degree claiming things about contraception, there's just so much out there. And it would be lovely to clear up some of that speculation and answer some questions about that.
Yeah, let's use this time to share evidence-based information and demystify and debunk the myths out there. Some that are perpetuating the disinformation that have questionable intention. But I think more often that providers of these disciplines just simply don't have the information or have access to the information. Something that comes up a lot is just hormones. What are my hormone levels? Should I be checking my hormone levels? Are hormones bad at a certain age, whether you're an adolescent who is suffering and missing school because your periods are so miserable, to those who are peri and menopausal? The hormones are just the topic of conversation a lot. What is your experience with people asking about hormones, and what should we be doing when people say, I think I need to check my hormones before I start any sort of medication that involves hormones?
The first thing I do when someone asks me that question, I always ask, oh, tell me a little bit more about where that's coming from. What is the motivation a person has when they're asking about hormones? Because there's probably a reason, right? Maybe they're suffering from menopausal symptoms. Maybe they are having occasional hot flashes, or maybe they're having other vaginal symptoms. And one of the things that our patients often present to us is asking the question should prompt us to ask more questions. Because a lot of the times we know as providers that checking hormones isn't usually the answer, because hormones do fluctuate, and hormones fluctuate based on the time of day, based on what you had, how you're feeling, if someone is stressed. And really, it's the clinical picture and scenario that really drives our care. And so asking our patients, what are they feeling? And then reassuring them, checking that the hormones really probably won't do too much. There are some situations in which checking hormones are helpful, but for a general provider providing teen spectrum care, that's usually not something that we're doing. I think the only instances when I check hormones, if I'm worried about someone not having periods and they're supposed to. But there's also a different kind of workup for that, right? Are they pregnant? So some of those other labs and clinical picture is more important than the actual hormones.
Those are great points, because I think, again, the intention or the worry is sometimes lost in the advocacy for this is what Dr. Google or ChatGPT or something told me that I need to do, when really as clinicians, we should be asking ourselves, will this information change our management? And I think in the case of hormones, short of these exceptions, particularly when we're thinking about how hormones interplay with contraception as the goal, is not going to change our management in most situations. Clarifying what the worries are for the patient, for the guardian, if they're with the patient, if they're younger, or the adult child who is with their parent, is definitely a good starting point to just get on the same page, because some of these worries are so big, but actually are nothing more than just worries. And we can actually provide some good help without doing a blood draw.
Yeah. Sometimes we really just need to dig into what are the reasons, what are the worries, what can we help? And a lot of times we can do a lot of help without doing these unnecessary procedures. And not just unnecessary, but unhelpful.
And when it comes to the lens of contraception, I think there are, again, big picture worries from patients individually, regardless of age, from parents or guardians when thinking about starting their kids on hormones if needed. I have come across a lot of questions from both colleagues and patients and families of what are the different types of contraception? And we know there are a ton of resources out there for both patients and clinicians. How is contraception in general different than emergency contraception? Are these things that cause abortions? Could you speak a little bit more to your counseling about general contraception?
So contraception and emergency contraception are generally pretty different things. And emergency contraception is not an abortion. And so that's one of the first things that people are worried about, is I tell them that emergency contraception only delays ovulation. And so it's not, if embryo is already implanted into the uterus, it's not going to induce an abortion. It simply cannot do that. Some of the dosing medication, it doesn't have that functionality of doing that. And a lot of times people are worried that, is this what an abortion is? Abortion is not that. So emergency contraception is typically taken within 3 to 5 days after unprotected intercourse. And that could be a pill, and that could be an IUD, depending on the availability of providers. And again, neither of those disrupts an already implanted pregnancy. So when it comes to contraception, there are a lot of different methods, and it doesn't really matter. There are different medical eligibility. So there is a really great app called the Medical Eligibility Criteria, or the CDC MEC guidelines. I encourage everybody to download it. I used it throughout residency training. I still currently use it. It really helps you get a clear medical guideline about what medical situations this particular person is safe to have contraception. The way I approach contraception with all patients is really like having a conversation with the person, right? Yes, we have the medical knowledge, but then at the base of it, we are arming our patients with the tools of what they choose for them, because most of the studies shows that what they choose is usually what they want and what they'll continue.
Because we know that any of these methods won't work, maybe short of the long-acting reversible methods, if there isn't buy-in from the patient and this is their life, right? I think there's often maybe well-intended, maybe not well-intended stances from providers of thinking this method would be best for this person. This person is terrible taking any of the pills that I prescribed for their other medical conditions, and now they're asking for the birth control pill. So it feels maybe you're not setting this individual up for success by prescribing another pill that they're going to put with their other pills. But the stakes are often different for people if they think of a different medication for a different indication compared to an unintended pregnancy.
If we insist on another kind being more effective, or we think that works better for them, then they're more likely to find another provider and not trust this particular provider, because then they feel like they weren't hurt. And maybe next time this patient will be like, yeah, I'm willing to try that now. And that's a huge win. And a lot of what we do is trying to keep that trust and maintain that trust between a patient and provider.
And thinking about it through a reproductive justice lens, an autonomy lens, there is a pretty marred history, health inequities, things that are just blatantly wrong, that we have maybe to spend the rest of our career trying to earn that trust back. And one way to not do it is to tell someone what you think is best for them.
Yes, exactly. People have agency to make their own decisions. And it's okay to be unsure of what they want to do as well. I always say it's not our emotional burden to make decisions for other people. It's our emotional burden to take care of ourselves, but we don't have to go to that lengths for every single person, because they have agency, they have control. they can decide. Sometimes it's harder when there are complications and nuances, when there is less control and less agency. And that's a whole nother story there.
That's another podcast. And that reminds me of the assumptions that some clinicians can make, which is assuming that the person whose chief complaint or, what the visit on your schedule little blurb says is contraception, right? I think sometimes we also make the assumption that this person in front of us with whatever variables they have, of course, doesn't want to get pregnant. So one of the assumptions that us as clinicians need to step back on and be aware of, at least, is it's possible that the person you're meeting, again, regardless of age, might actually want to get pregnant. They want to talk about that, even though contraception is what's listed down. How do you begin your counseling about contraception or potential contraception with this assumption that sometimes happens in mind?
I think assumptions are our worst enemy, that's for sure. With any conversation, I think it's really good to open with an open-ended question. Are you interested in getting pregnant in the next year or so is a great opener. Or what are your thoughts about different forms of contraception? Or what have you used in the past that works for you? Or another great question is, what is the most important thing for you in terms of contraception, if that's what we're talking about today? And sometimes it's not about preventing pregnancy. There's so many non-contraceptive benefits for contraception. So, for example, abnormal uterine bleeding, menstrual cramps, headaches, migraines. There's a lot of different reasons that somebody may want contraception, and they may not pertain to preventing pregnancy. Really knowing what are the goals. And some people can have multiple goals. Some people might have one goal. Clarifying and trying to work with that person. It comes down to it is how can we work with the person in front of us? How can we do the shared decision making, really work together as a team and come up with a great plan?
You bring up really excellent points because I do think that's a common misconception of these medications are for birth control, period, full stop. And that is just not the case. And oftentimes that could be one of the goals, but like you said, there often are multiple goals for folks. And that reminds me of another misconception, which is related to menstrual suppression. So some people just may not want to get a period. It's not working for them. It's cramping their style. They're missing school or they're missing work or for no specific reason. They just don't want one. And that comes up in my line of work too, because parents often are like, it can't be good or healthy or safe to not have a period. What do you think, doctor? And what would your response to that be?
I would say if you are not taking medications to prevent bleeding, you are correct. It is not healthy to not have a period. But if we were to purposely suppress the periods, then it is normal and safe. The reason being is that when we're taking the medications to stop bleeding, it actually thins out the lining of the uterus, and therefore, of course, you're not going to have bleeding. So once somebody is, we quote unquote, called menstrually suppressed, it is safe to continue to be that way for the foreseeable future.
And that goes back to your initial point of amenorrhea, primary or secondary, right?
Mm-hmm.
It's very different than I've had periods or I have periods or my periods may be irregular, they may be miserable, and I want them to stop. And so that's a helpful clarification point because this does come up a lot. Another thing that I find comes up a lot is, okay, so you've had this conversation, you've determined what the goals of the patient are, you've done your counseling on the various types of contraception. When can you start it? Do you need a pregnancy test that is negative? What if unprotected sex happened in the parking lot before this appointment? How do you navigate when to start? We've heard this term quick start. We've heard you need to start the Sunday after your next period, which is who knows when that's going to be. So that's a risk of unintended pregnancy for however long that's going to happen. How do you counsel or in a shared decision-making way determine when to start contraception?
You're totally right. The longer we delay, the more likely somebody could get pregnant. And so I always counsel say it's perfectly normal and healthy to start it today. And even if you were pregnant right now, it would not negatively affect your pregnancy because A true pregnancy, now amount of hormones is way higher than the medication in these pills. And really, there is no difference in bleeding pattern, doing the quick start method, meaning starting today, versus waiting till what the pack kind of instructs one to do. I remember actually when I was a kid also asking this question. I think I was 18, wanting to control my bleeding and my periods. And the provider said, just start it today. It doesn't really matter. Whatever you want to do, just start today. I said, okay. And it's funny how I am now almost 40 and we are still having the same questions.
Same. I know. It's wow. We've had so much time and the medicines, some have changed, some haven't. And we are still having the same worries and the same conversations of we are still countering misinformation and disinformation just like before. Things related to contraception causes infertility, cancer. None of these are evidence-based, but it's amazing with social media and just word of mouth within communities, particularly the power of lived experience, right? So we don't want to diminish if someone had a terrible experience with insert whatever contraceptive method, then their friends and family maybe, oh, remember Susie Q over there? She had a terrible experience with that. And that's not necessarily disinformation, right? That's someone's lived experience. And that was true for them, may not be true for the person in front of you. And differentiating that from blatant disinformation, which is contraception causes infertility, for example.
Yeah, I love how you said that it's true for that person, but it may not be true for you. So we do absolutely have people come in talking about some horrible experience that their friends or their family, which is really like the most common thing I hear is when a family member or friend have had a negative experience. And then I really want to hear about that experience and hear how they're handling that experience too. And what are the concerns? I'm not trying to fact check them, right? Because that is how we backtrack ourselves. We really just want to validate those experiences and understand that sometimes complications do happen. We're not magic as providers. We can't pretend everything is always okay. But knowing that and being really just transparent about what we can or cannot do with our patients makes them trust us a lot more.
Yeah, and the anticipatory guidance of what to expect when you start a certain method, what may happen, and then we can troubleshoot if those things occur. Like your friend, this breakthrough bleeding with her contraceptive implant, that was terrible for her. What would we do if that were to happen to you if you chose the contraceptive implant? I think there's really a lot of power in the anticipatory guidance realm of not trying to dissuade or convince someone to do anything. That's how we get ourselves into trouble. Like you said, that's how we lose trust. That's how someone's going to be like, oh, my perception, even if that wasn't the intention, is like this doc told me that I need to do this. And if I don't, then this is going to happen. And nobody wants that.
The other thing that I feel like I hear a lot is, will the IUD prevent me from being pregnant? Will it cause fertility issues? It's such a valid question because just to clarify with all the providers out there, that historically the Dalcon Shield did actually lead to infertility. So the Dalcon Shield was an IUD made many years ago. If you Google it, it looks a little bit like a bug. And so what happened is that in the past, there was an increased risk of infections for people who had Dalcon Shield. And then that would lead to infertility because we know that infection can lead to infertility. But the new IUDs, which is the only IUDs we have on the market, and this includes anyone with levonorgestrel or the copper IUDs, does not. And simply because the strings on the end of the IUD are monofilaments and not polyfilaments. So the polyfilaments actually cause the bacteria to be able to literally travel up the IUD into the uterus and would hence cause infection. So it's one of those things that I will explain to patients about this history so they understand that we take it seriously, right? And so I will do the storytelling, exactly what I just said to our patients, so they understand the difference. So they know that I'm not making it up because it is really hard, again, to gain that trust.
Speaking of particular contraceptive methods, there's been a lot of talk recently about the Depo shot, Depo-Provera, and the new studies that have come out, and we can include those citations in the description of this podcast, about how Depo has been found to be associated with meningiomas. And Meningiomas are a benign brain tumor, not even brain really, it's usually typically the base of the skull. And that sounds really scary. That sounds really scary to a lot of people. And I think it's important that we proactively try to get ahead of these misconceptions related to this because the studies are certainly valid, but there are some details that I think can really be missed and overgeneralized in terms of what we're seeing out there. A colleague of mine recently did a journal club on these articles, and during his presentation, he showed a screenshot of a search engine. Take your choice of whichever search engine you prefer. And he typed in Depo shot and meningioma. And the first, 5 links that came up were actually law firms, like touting how they're ready to go in terms of litigation related to this. And also as part of that journal club, he brought up some really important points, which really specify that the risk that they saw between Depo shots and the meningioma was related to prolonged use or over 4 years, typically, or initiation like past the age of 31. And while that applies to maybe a good chunk of people, and the results were statistically significant, but clinically really still pretty low, that nuance was missed from the search engine. Yeah, what yielded from that. And so if you have someone come into your office and says, I've been on the Depo shot, I need to get off of this right now. I really loved it. It really worked for me, but now I'm terrified I'm going to get a brain tumor. How would you approach that?
Yeah. And I would first say, absolutely right. Let's talk a little bit about what that study showed. And so, what that study showed is that there was it is a big study, observational study, where they followed people and they saw that there is a 5 in 10,000, so 5 people per 10,000 risk of developing a meningioma with the Depo shot. And then in France, their baseline risk was 1 in 10,000. And the study shows that more than 2,000 patients have to use Depo for one new case of meningioma. So yes, it's statistically significant, but is it clinically significant? That is the question, right? I will literally tell people some of these numbers, right? And again, it is very specific to say, don't say percentages, because percentages really have a difficult meaning, but a 1 person in 10,000 is a much easier number to understand, right? And so that's what I would say. I would say, look, it is an interesting article and it means that we have to keep looking into it. But does it mean you have to stop your Depo? We don't know, right? There are a number of different things. But if we also have to look at the other side, if this particular person in front of us, that is the only one they like, and the alternative is risking pregnancy, and many people, pregnancy is way riskier than the actual medication. We have to weigh those risks and benefits. The patient has to weigh them, right? So they have to risk getting pregnant. And we know that being pregnant is a very particularly difficult thing to manage, right? With the maternal morbidity and mortality that's on the rise, with the abortion restrictions depending on where they live. And when it comes to reproductive care, it is a nuanced subject that we have to take each person individually.
You bring up a great point of really when counseling about any of these methods, certainly we talked about some particular things related to Depo, the alternative always needs to be viewed through the lens of an unintended pregnancy and how that impacts a person's life forever, maybe for the rest of their life. The impacts, especially in my patient population that are adolescents and young adults, there's all the usual risks that come with a pregnancy, including the ones that you had mentioned. But then it's like the impact on graduating high school, the impact on being able to manage getting a job if one chooses to go into the workforce or higher education. These are significant risks that are hard to measure rather than your 1 in 10,000 risk of a meningioma or your X amount of risk for a blood clot with an estrogen-containing agent. Talk about a hypercoagulable state is the pregnant state. Correct. So I do think we need to be sure that we guide our patients to think through these risks. Like to your point, it's them. They need to weigh the risks for themselves. Our job as informed clinicians is to provide them the evidence-based information for them to consider so they can make the most informed decision for themselves in this world of chaos, frankly.
That's exactly how I approach it. I kind of take them through a journey of where their life would be if things were to occur. Because sometimes it's hard to make that connection on our own, right? And this is the space and time, right? Taking care of someone does mean taking care of them as a whole person. And so I do think that reproductive needs is a lifetime of needs, right? And so whatever we can do to really help support the person in making that decision at that time is what we try to do.
Yes. And for adolescents, it is developmentally appropriate for them to be like in the moment right now. So they really need some extra assistance in thinking about the future, but not too much focused on the future, because then we might lose them because they're very present minded. Not all adolescents, but again, as a developmental stage that is adolescence, it's like smoking cessation. Certainly you can counsel on the long-term risks of smoking, but sometimes what's going to be most important for a young person is like the immediate risk. Oh, my breath might be bad, or the money I have for my after-school job is going to be depleted because vapes and cigarettes are so expensive. And so it's important with multiple things that we counsel our patients on, depending on their developmental and cognitive state. That's not always directly related to their chronological age. We're taking that into account for our counseling, regardless of what it is, but particularly for contraception and reproductive health.
Speaking of that, Dr. Bostick, I have a question for you. How do you handle it when patients' parents ask you if hormones will stunt my child's growth?
There's just no evidence of that. We know in other contexts, precocious puberty, for example, that can stunt growth because the growth plates are sensitive to sex hormones. But similar to your talking point earlier, that if we are using contraceptive methods for a different purpose, the details aren't always the same, right? So not having a period is very different than using a medication to stop your period. And similarly, depending on the age of the person, depending on when menarche was, like if menarche was several years ago, like they probably are done growing. Their growth plates are probably closed at this point, not always. But I think what comes up more for me is back to Depo, and I certainly don't mean to pick on Depo, but is some of the bone health stuff. Like that has been talked about a lot, that has been studied longer. And what we know is that, yes, there is a chance that bone mineralization, especially during these years of adolescence, which is when you're getting the most mineralization, it can diminish with Depo use. But what we also see is that catch-up happens and remineralization happens when you stop it. And most of my patients, if they're on Depo, they're not always on it for very long. And we know from the French study that with at least meningioma risk, duration of use does matter. I certainly have people who love their Depo shots, but I also have people who are using Depo as this medium-acting method as a bridge to protect themselves against unintended pregnancy for now. And maybe they're considering an IUD or a contraceptive implant, or maybe they're just not sure and they just want 3 months to think about it more. And I talk more about that, but I also try to bring up the sort of factors that also come into play when we think about growth, linear growth in general. And I also want to be sure, again, to our points from before, that the alternative could be an unintended pregnancy.
For us, I think as OBGYN providers, Depo, is not commonly used continuously for a long period of time. We do tell patients about that black box warning, talking about the risk of demineralization. But it's generally, like you said, it's well studied that it gets better within stopping it. And there are other issues with Depo, I would say, that are more likely to occur. There is a little bit of possible weight gain, like 5-pound weight gains per year. But in general, it's well tolerated. People like to use it, especially like you said, as a bridge between types. But it's just interesting to hear from your perspective as talking to parents.
Yes. And I would say more often than not, at least in my anecdotal experience, many patients and many parents have their own opinions from their own lived experience. And sometimes they're helpful in guiding decision-making for the young person and what they want to choose for themselves. Sometimes less so, not on purpose, but again, similar to IUDs of the past, the memory of that is just so at the forefront of the brain when it's just not pertinent or applicable or real anymore with the more modern devices. And again, the power of that lived experience, to your point, we need to recognize and validate it, because if we don't, then we're going to just lose everyone. You're just going to be like, oh, I didn't feel heard, I'm not coming back. And so it's delicate to validate, but also not let, it doesn't even have to be a parent, it could be a partner, it could be a friend, their lived experience to derail the informed decision making for the individual patient in front of you. So I find in my experience, it's a lot of recognizing, but also bringing it back to the person in front of us and how this affects their decision making or how this may impact the choice that they make that would be best for them.
Absolutely. It's always a yes and situation, right? Yes, I totally hear that happened and does not sound pleasant or whatever we want to say. And this still could be an option for you. And so it's one of those things that historically there is absolutely a really good reason to distrust the system, providers, right? There was forced sterilization in the past. So to pretend that it doesn't exist or to dismiss it does automatically put us at a disadvantage with our people, with the people around us. So if we want them to trust us, we need to do our research and understand and know our history, because our history is rooted in experimentation and we have to be careful.
Discrimination and racism, all of these unpleasant but very real truths are
Still present to this day. Yeah. So we have to hear our patients' needs and move forward together as a team.
absolutely. And recognize that implicit bias is also very real, as is explicit bias. And so both of these things need to be called out. And I think that's what we try to do in our day-to-day. And we would encourage our listeners to really do some self-reflection, educate yourself on the current things related to contraception, understand what misinformation and disinformation is out there, and have a strategy to counter it while also acknowledging the hard truths.
Yeah, it's hard to hear all the misinformation from our patients all the time, I will say, but it does make me motivated to look at what's happening on social media. I'm not a social media person, but I use it specifically to see what people are saying.
All right, wrapping up, if you had one, I feel like I just did mine, but if you had one takeaway message for misconceptions about contraception for our listeners, what would it be?
I would say really clarify where the misconception comes from and come with curiosity rather than judgment. And then that will unfold a lot of misunderstanding or distrust that occurs, and then you can get to a place of shared understanding.
What a beautiful way to end. Thank you so very much, Dr. Sun, for your time and expertise. And thank you for our listeners for checking out Misconceptions about Contraception from CEI.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.